Here it is. Okay, so good afternoon, everybody. Thank you for joining. I'm Sanja Hermans, and I work at the Institute for Medical Genetics at the University Hospital Tübingen in Germany. And I'm the training manager for the European Reference Network for Rare Neurological Diseases. Let me just share my screen. And we can start. Okay. So we have today a webinar with the topic mitochondrial disorder with Chorea. And this webinar will be presented by Martin Paucar from the Karolinska Institute in Stockholm. I will give you some general information about the webinar today. So this is the 8th webinar in our series, which we are organizing jointly with the European Academy of Neurology and the European Reference Network for Rare Neuromuscular Diseases. So we are covering here topics on rare neurological, neuromuscular, and movement disorders. Normally, the presentations take around 30 to 35 minutes, and we have like 15 minutes time for questions and answers afterwards. So please write your questions in the Q&A box, which is in the lower toolbar on the left side. And of course, if you have some general questions, you can write them also in the chat box. The target audience of our webinars are neurologists, residents, pediatric neurologists, geneticists, and all the other non- or paramedical personnel involved in patient care. We are recording this webinar, so we will put the recorded version and the slides at on our website, which you can see here. And if you like to see some more information on this disease group, you can visit this website. So at the end, your browser will automatically open a post-webinar survey, which should take only 2 to 3 minutes. So please just tell us your satisfaction. Maybe you can enter some ideas and suggestions about topics or speakers you would like to see here in our webinars. Okay. So since we have attendees from all over the world, I just wanted to say a couple of words on the European reference networks. Here in Tübingen, Germany, we are coordinating the European reference network for rare neurological diseases. There are 23 other European reference networks, each of them handling another disease type. So here in our ERN, we are covering 6 disease groups, and those are ataxia and HSP, leukodystrophies, dystonia, Chorea and Huntington, FTD, and atypical Parkinsonism. So the network is actually a group of several expert centers and healthcare providers around Europe. And it has been created to facilitate and intensify the collaboration between those expert centers and the clinicians working there. And of course, the ultimate aim of this collaboration is to provide for the patients a timely and accurate diagnosis and a proper treatment and care. Okay, so I'm very happy today to have Martin Paucar from the Karolinska Institute as a speaker for our webinar. Martin is a neurologist specialized in movement disorders, and he has he obtained his training in medical studies in medicine in 2005 at the Karolinska Institute, and conducted his PhD on familial hyperkinetic disorders and obtained his degree in 2007. And he is member of the Huntington's disease clinic at the Karolinska University Hospital, and is doing a postdoc at the Per Svenningson's laboratory with research focus on ataxias and paraparesis. So Martin, thank you very much for accepting the invitation. And please
yes,
go ahead with your presentation. I will just stop sharing my screen and start.
Thank you for this kind introduction, and thank you to Professor Adrian Danek for inviting me to give this talk, and to Sania for organizing the logistics. First of all, we would like to have a sense of the attendance professional background. So yes, if you please tell us a little bit about your profession, just to have a sense of, yes, our target audience. Please, can you vote? Here are the options. So you vote, we collect the results, and I think Sania will display them on the screen.
Yes. We will wait for some 30 seconds more, sure, and then I will show the results. Okay.
Okay.
So here are the results.
So we have, well, the majority are adult neurologists and residents, and we have, well, other groups as well, researchers and neuropediatricians. Okay, let's get started. Mm-hmm. Let me close this and move on. Let me see. This is my only disclosure for this talk. This is an overview of what I am presenting today. I will give you a case presentation. We'll describe a patient affected with a hyperkinetic syndrome, discuss the phenomenology, and based on that, the differential diagnosis, and how to reach an etiology of this complex presentation. So these are the learning objectives of this activity, as implied in the title, to discuss the differential diagnosis of chorea and how to evaluate patients with a suspected mitochondrial disease. So this is a case presentation. This is a patient that I have been following for the last 10 years. She is 71 years old. She was born to non-consanguineous and healthy parents from this minority in Turkey, the Syrian minority in Turkey. She emigrated to Sweden in the early 80s, and is a widow and has 2 healthy sons. There is no family history of neurological or psychiatry diseases in this family. Her past medical history is relevant for type 2 diabetes. This patient went through a hysterectomy also, and she had other onset bilateral hearing loss and requires a hearing device. During the course of our investigations, we found that she had a thyroid follicular tumor that was benign and removed. And finally, she has something called alpha thalassemia trait, and harbors the 3.7 deletion in the alpha globin gene. And it is very rare that alpha thalassemia causes symptoms. I mean the trait. So the history of present illness, she was referred to us because of involuntary movements and a gait disorder. We couldn't determine the age of onset for these motor symptoms. Well, her relatives described that at the age of 52, she's presented with short memory problems and also had difficulties carrying activities of daily life. 4 years later, she developed olfactory hallucinations. She perceived a very bad smell all around her and became obsessed with cleaning and doing laundry in order to remove this stench. And this created conflicts with, with his neighbors. She could go down to the common laundry room and throw away the neighbors' laundry because she perceived that they got this very bad smell. 2 years later, these hallucinations were so unbearable that she attempted to commit suicide by setting her apartment at fire. Well, she was rescued and she was admitted to special psychiatric ward. It's a sort of prison for patients with mental conditions or psychiatric conditions who commit crimes or are sentenced to prison but cannot be sent to prison. The staff member noticed that she had cognitive difficulties, but no formal evaluation was made at the time. An important piece of information here is that the patient is illiterate, and it was considered that her performance or cooperation would be limited for this. And she was treated with haloperidol first, and later with aripiprazole. And the olfactory hallucinations, disappeared. She ended up spending 1 year in a psychiatric ward and referred to us upon discharge by the general practitioner. Now, this is a video done in 2 different occasions. I want you to, this is to illustrate the phenomenology. Pay attention to the movements in her hands, around the face, and the posturing. And pay attention to the gait. And 4 years later, so This next slide. Well, this is a summary of the phenomenology. I hope you will agree with me that the main feature here is chorea, particularly in the feet, around the mouth. Also intermittent chorea is found in the or seen in the trunk. There is some just posturing in the hands, an absence of arm movements, but also an important feature here is her gait. She got a waddling gait, and also displays bradykinesia. It's also evident during the examination that she has apraxia. The instructions have to be repeated several times, and her short of attention is also limited. Well, no, and let me, yeah, there are other features that are no, well, that you can see in the video, such as the strength. It was reduced in both arms. She has also a mild atrophy in the hands. However, her reflexes and the muscle tone are normal. And also, let me emphasize that these hyperkinesias were present for many years before treatment with neuroleptics was started. And that was being reported by the relatives, but also witnessed by hospital staff members. The patient came to the ER several times complaining about different symptoms before she attempted to commit suicide, and that has been witnessed and documented that she had involuntary movements. So now I think it is time to vote, and the first questions to you is about her gait. Waddling gait is highly suggestive of paraparesis, myopathy, chorea, dystonia, or none of the above, and only one answer is correct. So take your time and vote.
Okay, 30 seconds left. You can still vote. There are 67% of all attendees that have voted until now. Okay. So here are the results.
Yeah, and the majority voted for the right answer, myopathy. Exactly. Myopathy. Good, well done. Now, let's move on to the next slide. This is a summary of the investigation. So this is a baseline. We have a patient, this complex story phenomenology, and we did this investigation. So the most important are summarized here. The routine labs, CK and myoglobulin levels were all normal. Initially, her lactate levels was normal, but last year found to be elevated. She got a microcytic anemia explained by her thalassemia trait. And we did also a lumbar puncture, and all the standard parameters like cell count, albumin levels, electrophoresis were normal. And we also measured markers for degeneration, meaning tau, phospho-tau, beta-amyloid, neurofilament, and they were normal. We didn't find any autoantibodies in her serum or CSF. We did repeated EEG studies also at the time when she was admitted to the psychiatry unit. People had a suspicion that she may have temporal lobe epilepsy, but none of these studies revealed epilepsy whatsoever. And finally, other neurophysiological tests demonstrated that she has, in fact, a myopathy and demyelinating polyneuropathy. So, and the next step was to perform neuroimaging, and it was not contributory. What we found was wider perisylvian sulci reflecting atrophy in the frontal and temporal lobes. There were also some non-specific periventricular white matter abnormalities, and the FDG PET study revealed hypometabolism in the atrophic areas. So now I think it's time to, no, it's not for, and for reasons you start to see, we did also a cardiac evaluation. We did repeated electrocardiograms. We measure also pro-BNP levels, and they were normal. And pro-BNP, as you know, is a marker of heart failure. So we also every year have done echocardiography studies, and what we have found is a non-progressive ventricular septum hypertrophy, but normal ejection fraction. So I think we have more information. And now, another question to the audience. So what is next step in the investigation? And also one of this is the right answer. Number one, muscle biopsy. Number two, sequencing of mitochondrial DNA from the muscle biopsy, or to do whole exome sequencing, or all the previous. So please put your vote. Let's see what we get this time. So are we done with the voting now?
No, 30 seconds left. But the majority have voted already.
It's not a competition. This is just to make the seminar more fun.
Okay. Those are the results.
Okay. Yeah. Let me see. Half of the attendees vote for the first one. The right answer in this case is number 4, all the previous. And let's see the rationale for. Let me see if I can move on. Here we go. We did a muscle biopsy, and we found, to start with, and we found COX negative fibers and ragged red fibers, and also predominance of type 1 muscle fibers. However, the complexes in the all the complexes in the respiratory chain were normal, and also normal was a sequencing of mitochondrial DNA. So important considerations, take-home messages: a normal muscle biopsy, a normal biochemistry does not rule out mitochondrial disease. And also consider that lactate levels are very variable in mitochondrial diseases. You know, mitochondrial diseases are quite pleiotropic, and these lactate levels are, well, some people consider them as biomarkers of mitochondrial disease. They are not. And whole genome sequencing can be configured to cover both nuclear and mitochondrial DNA. That is a limitation with whole exome sequences. So that is the reason why the last option was the right one in this case. Now, this is another question I have for the attendees. Now we have more information on the patients, and now you need to decide which is the most likely diagnosis in this case: MELAS, Paul-related disorders, another rare or more rare mitochondrial disease, Huntington's disease, or any of the Huntington disease-like conditions. Any of the 4 here is accepted as correct, or any of the 2 classical neuroacanthocytosis syndromes, Chorea acanthocytosis or McLeod syndrome. So please put your vote, and let's see what we get this time.
30 seconds left. Okay, and here are the results.
Okay, there are some, it's quite split between the different options, and now we will discuss each of these conditions. The right answer was number 3, another rare mitochondrial disease. But let's go through the options. Let me see this. Here you go. MELANS is the acronym for mitochondrial encephalomyopathy, lactic acidosis, and stroke-like episodes. This patient did not have any stroke-like episodes or migraine, which is common in MELANS. And this condition is also associated with very typical or characteristic abnormalities on neuroimaging, widespread white matter abnormalities. And up to 1/3 of patients with MELAS have brain calcifications. She did not have this. And now for Pol-related disorders, well, mutations in Pol-G cause a wide spectrum of different disorders, quite pleiotropic. However, diabetes and cardiomyopathy are not common features for this spectrum. And now we have some pediatric neurologists here. You cannot talk about hyperkinetic mitochondrial disorders without mentioning Leigh syndrome. Leigh syndrome was not an option here because it is also associated most often with infantile onset, and it has a subacute relapsing presentation with encephalopathy, movement disorders such as Chorea dystonia, and also typical neuroimaging abnormalities such as necrotic changes in the basal ganglia. So now let's move on to the other options. For Huntington's disease, caudate atrophy is a hallmark of the disease. However, it's not specific. You can see caudate atrophy many years before phenoconversion, and this patient did not have caudate atrophy. And now and also HD and the other lookalikes, the other 4 autosomal dominant disorders in our list, don't have cardiomyopathy as part of the syndromes. And all these diseases were ruled out in our case. And here, finally, hearing loss and diabetes are no features of HD, the HDLs, or the 2 classical neuroacanthocytosis syndromes I mentioned. So let's move on. So this is a summary of our genetic findings. We did a whole exome sequencing at the time and found 2 new variants in this gene called ELAC-C ribonuclease C2, ELA-C2. Both variants were in trans. The patient's healthy son, the youngest one, is a heterozygous mutation carrier. Now, our task was to determine whether these variants are or no the cause of head disease. What do we know about mutations in ELA-C2? Well, mutations in this gene cause this autosomal recessive disease called combined oxidative phosphorylation deficiency 17, described for the first time in 2013. Hack and co-workers described these 5 patients, 5 children, affected with this severe hypertrophic cardiomyopathy that is often lethal. So the presentation is quite early in life, and probably this cardiomyopathy overshadows all the other symptoms. In terms of the neurological features of this disease, you will have or find that some of these patients have psychomotor delay and also muscular hypotonia. Some patients have microcephaly. And as you see, the second patient here also has sensorineural hearing loss. And also a recurrent finding in some of these patients is intrauterine growth retardation and dysmorphia. One of these patients had a COX negative fiber. So this is the clinical presentation. a severe cardiomyopathy. 3 of these patients die early in life, and the presentation is early onset. So it really didn't fit our case. So we kept looking, and this is from the same article. Hack and co-workers looking at the biochemistry of mitochondrials, and they found that in all cases the respiratory chain complexes were impaired. They also found an accumulation of transfer RNA in different tissues. So this is the first paper. 4 more papers came out later. This is the second one in a Pakistani family, consanguineous family, 5 affected children. And in this case, the cardiac presentation was minimal as compared with the first case series. However, global developmental delay was present in all the patients. Some had microcephaly and mild dysmorphism. All but one were unable to walk. And in terms of neuroimaging, one patient had cerebellar hypoplasia, and a second one hyperintensities in the basal ganglia. And again, this patient had mild septal hypertrophy. The oldest living patient in this family was 25 years old. And also similar to the work done by Hack and co-workers, there was an accumulation of unprocessed transfer RNA. So we started to wonder, well, still our patient was much older. And now another paper a year after came from Saudi Arabia. This is a screening among consanguineous families with cardiomyopathy. These researchers found 16 cases. All these children died of hypertrophic cardiomyopathy or dilated cardiomyopathy, and the mean age of onset was around 4 months. And again, these children presented with psychomotor delay, hypotonia, microcephaly, dysphagia, and sensory neural hearing impairment. So quite lethal disorder. And this is a latest paper from last year, a larger cohort, larger cohort than the first paper by Hack. Sauer and co-workers described as 13 patients. The majority have hypertrophic cardiomyopathy. 3 had dilated cardiomyopathy. And again, onset was either right after birth or during infancy. 2 of these patients had a heart transplantation, and 8 of these children died early during childhood, and the oldest living one was 19-year-old. All but one had lactic acidosis, and all had deficits in the mitochondrial respiratory change, and most displayed developmental delay, and one had cerebellar hypoplasia, another one had myopathy, and another one polyneuropathy. And now, what do we know about the gene function? ELAC2 encodes for an endonuclease that is responsible for the removal of the 3' extensions from transfer RNA precursors. And this process is essential for, or this step is essential for nuclear and mitochondrial processing of transfer RNA. And this is going to have an impact on the balance production of other non-coding RNAs. And of note is that this group by Seed and co-workers did a knockout mouse for ELC2, and as expected, these embryos were not viable. So now going back to the first paper by Hack and co-workers and looking at the biochemistry, I mentioned that, well, these researchers found deficits in respiratory chain complexes. But I want you to pay attention to cartoons B and D. These are northern blots. And the idea is to analyze RNAs, different types of RNAs. And these researchers did not find any differences in the normal state levels of mitochondrial messenger RNA and mitochondrial ribosomal RNA. in patients and healthy controls. However, they found, here you look at cartoon D, and these bands in the middle represent accumulation of unprocessed mitochondrial transfer RNAs and messenger RNA intermediates. And I mentioned before that some patients have COX negative fibers at our case, similar to our case, and in one case, biopsy was taken from the heart of these children, and these researchers found a large mitochondrial and abnormal crystal. So, going back to our case, and remember these two cartoons, D and D, we found exactly the same pattern in our patient normal steady states of RNAs in fibroblasts. These are again northern blots, and we see also in the middle accumulation of unprocessed transfer RNAs. We did another experiment looking at the growth of fibroblasts using galactose as a medium, and you can see here in gray the cells from our patient as compared with healthy controls, and the growth is quite impaired. So, taking together, this convinces us that these pathogenic variants in our patients were, causing the disease. However, we ran into an unexpected finding right from the beginning. I put it here to the end, just to have a discussion of, this is what we found, acanthocytes. And first, I thought this might be an artifact and didn't do much about it. I repeated it twice, and they kept coming back, and that made us reconsider. So are we missing something? Are we missing a neuroacanthocytosis syndrome? And we also asked our hematologists, what do you think, any connection? Remember, this patient has the alpha thalassemia trait. Is there a connection between these two conditions? There is not. And so we did a reassessment of the whole exome data, and we couldn't find any mutations or pathogenic variants in the genes causing Chorea acanthocytosis or McLeod syndrome. And we also ordered the Western blot for Chorea done in by the lab of Professor Adrian Danek, and that Western blot came out as normal. So we look for similar cases, and this is the only paper that we have found of acanthocytosis in the context of a mitochondrial disorder. One single case in Japan, a patient who died of MELAS. Okay, and this is the cognitive evaluation. This is just to give you the whole picture of the complexity of this presentation. Remember, I described the patient as being illiterate, so we got to adapt a cognitive evaluation, and our psychologist did this test with Raven's progressive matrices, and found that she had an IQ estimated to 70, and she had also very low results in tests evaluating visuospatial episodic memory, immediate recall, and also deficits in spatial visual construction. It was very hard to evaluate her premorbid cognitive ability due to the socioeconomic circumstances of her upbringing, and also to the lack of relevant background information. And now the follow-up. What has happened? 10 years of follow-up. We made a diagnosis, and we started treatment with coenzyme Q10 used for other mitochondrial decisions. It's quite empirical. We are talking about very rare diseases. And she has been progressing slowly, depends now on a walker for mobility, has fallen several times, but refuses to move to a nursing home. She has developed urine and fecal incontinence, and she also, and a year ago, roughly, she had a sudden onset of slurred speech and ptosis, and upon admission, she did an MRI of the brain, and it showed a small infarction in the corona radiata. And 5 months after this presentation, she contracted a small frontal intracranial bleeding that was treated conservatively. And during the follow-up, she has been losing weight, but she's still able to move with assistance. And we put together our results and published this 2018. And to our knowledge, this is the oldest living patient with biallelic mutations in ELAC2. And this gene is nuclear. It's a nuclear gene encoding for a mitochondrial enzyme. This is the first time hyperkinesias and acanthocytosis are described in the ELAC2 disease spectrum. We are trying to figure out whether this association with acanthocytosis is just a coincidence. So you happen to diagnose cases like this, please contact us because we have been attempting to get a hold of the other researchers with cases like this, and so far we haven't been very successful. These are my conclusions. Chorea and dystonia are manifestations of some mitochondrial diseases, including COXPD17. This is a lethal disease. In total, we have 5 publications with 40 cases. 27 of these patients, children, die very early, but long survival is possible, as demonstrated by our case. And a recurrent effect of these mutations is an accumulation of unprocessed transfer RNA intermediates. And finally, we need to be humble and state that acanthocytosis must be assessed in other patients with biallelic ELC2 mutations. So acknowledgements to the patient herself for letting us write our publication, and to all these co-workers at our hospital. And with that, I thank you for your attention, and I am happy to take any questions. So please go ahead, Sania.
Yes. So until now, we don't have any questions. Would you like to write questions in the Q&A box? You have a time for that now?
Let me see if I...
Now there we have one question. What dosage of Q10 do you apply?
Let me remember. We are, well, in Sweden, we have this issue about prescribing coenzyme Q10 has been licensed only for patients with Leber's hereditary optic neuropathy. So we are using the generic, and the dosage is, that's a good question. Let me check into my papers. Hold on. I think while I look for the right answer, I can pass to the next question, please. And again, I mean, this is empirical. We don't have, of course, any evidence of that this is doing anything. It's just empirical because it's used for Leber hereditary myopathy. I think we are doing around, it's one dosage of in total 96 milligrams per day. This is the roughly calculation that we are done based on other prescriptions, and because we have to prescribe this in combination with an oil. Yes, 96, around say 100 milligrams of coenzyme Q10.
Okay.
Any other questions?
For the moment, I don't see any other questions. There is something in the chat box. We can check what is there.
Yes.
Yeah, so this is a patient representative, Alan Thomas from Wales, saying that a lot of patients report this dosage varies from patient to patient.
Yes, thank you for this clarification. Very nice.
Yeah.
And now we have Holm Grossner asking.
Yeah, this was the question that was
Okay.
before.
Yeah.
There are no other questions. Maybe in the meantime, I would just like to show one possibility to apply for fellowships and workshops for on rare diseases. Martin, would you mind to? So there is another one. It would be better to treat with idebenone.
Idebenone, yes.
Idebenone.
Okay, this is my answer. The company developing idebenone sue the Swedish state because they think that it has to be prescribed according to the evidence. So our local, what is it called? The Swedish FDA, the agency providing license or approving treatments, has been sued, and therefore, while awaiting a decision, I don't know if there is a decision yet, we cannot prescribe idebenone for off-label. We had to do this generic prescription. So that is the short answer.
Okay. Yeah. Martin, would you mind to stop sharing your screen so that I can show one slide, and maybe in the meantime we will get another question. It is for all of you among the attendees that are part or affiliated of in a ERN European Reference Network institution. So there are possibilities to get funding for short stays for 2 weeks up to 3 months outside of your country of residence. So if you go to the EJP website, I will put the link in the chat. You will get more information there. And please spread this information also to your colleagues who may be interested in visiting and in doing such a short scientific visit in another institution and learning more, some new technology or, yeah. Okay, so we don't have any questions left. So, there is one. More, how do you clarify the phenotype of a movement disorder and not wrongly include unassociated conditions? Example, in your case, how did you know that hearing impairment or DM is a part of the disease phenotype and not a comorbidity?
Good question. Number one, the presentation of these associations are based on certain criteria. I mean, the age when you develop hearing impairment, the pattern of the hearing impairment, and the other associated features. I think this is one we cannot be. I mean, this is an association made, I guess, by assumptions, but to prove them, we need to. I think we need to do pathology, and so far we don't have any neuropathological studies to go to the very bottom. Yes, it may be empirical, but this I mean, there are many unusual symptoms here, like the hallucinations were very striking, and also the myopathy. And you can also make an argument about polyneuropathy, but that is common in diabetes, yes. But I mean, so far we still have to see a neuropathological assessment of the, well, the central nervous system, the peripheral nerves, the hearing nerves. But it's a good point. It's an age. It was uncommonly early, and for that reason, we think that this was part likely of the mitochondrial phenotype. At least I want to emphasize that the presentation was quite striking for a mitochondrial disease. However, the psychiatry symptoms were also very, very unusual, very, very odd and dramatic.
Okay. Okay, so there are no more questions in the Q&A section, so we can close the webinar. Thank you, everybody. Thank you, Martin, for presenting this interesting case. And
thank you. It was my pleasure.
Thank you to all the attendees for attending, and see you next time. It's on 3rd March in another webinar in the disease group Dystonia. Have a nice evening. Bye-bye.
You too. Bye. Bye.